So in the symptomology, we have the conduct disorder here, emotional disorder here, relationship disorder here, developmental disorder here. Four patterns are in there in our child and adolescent psychiatry. Okay. So conduct disorders are the disorders which are characterized by a repetitive and persistent pattern of dissocial, aggressive, or defiant conduct. Then we have a conduct disorder which is often confined to family, maybe unsocialized, abnormal relationship with others, socialized, normal relationship, example with peers, oppositional defiant, commonly mixed with emotional disorder. Then management is family therapy, social support, depression, 10%, 10-year-old patients, 10% emotional disorder, 40% of the 14-year-old patients. Okay, they are having the depression and the emotional disorder. Then anxiety, mania, okay, depression in childhood, depression, boys and girls have same. In adolescent, girls are more prone to depression than boys. What is the management here? You can give the pharmacotherapy, drugs. We can go for family therapy. We can go for cognitive therapy, and we can go for the school life. Then we have the anxiety part, separation, phobic, generalized school refusal. We are having phobias and all, agoraphobia, social phobia, simple phobia, panic disorder, obsessive compulsive disorder. Dr. Farana, what is obsessive compulsive disorder?
Obsessive compulsive disorder is a part of anxiety or something which causes him to go into compulsion of washing hand repeatedly or hiding the fact that something else is a problem, but they express it with washing hand and not going out of the house and doing the same thing repeatedly, checking the doors and all that.
Very
But
good,
the
very
problem is lying somewhere other else.
So it is anxiety provoking, it is repetitive thoughts, it is intrusive and abnormal 5-HT transmission in OCD. In the yes, ma'am.
What is 5-HT? Histamine.
Yes, ma'am.
What?
In the brain and the transmission of our neuro that all these hormones. So abnormal hormonal transmission. Okay. Ma'am, in the mania part, it is very rare. Commonly it's misdiagnosed hyperkinetic disorder. Many of the child they are very kinetic. They used to run in the house. They used to play games and all, make sounds. So we think these child are having mania, but they are having hyperkinetic. In the adolescence, schizophrenia is been misdiagnosed to the mania. So first rank symptoms may be prominent: relationship disorder, sibling rivalry, the brother sister they are fighting, elective mutism, okay, attachment disorder, reactive disorder, disinhibited, okay, all the relationship disorders with the child. Then we have developmental disorders, pervasive developmental disorder, autism, Rett syndrome, Asperger syndrome. Autism is genetically influenced neurodevelopmental impairment, onset before 3 years, atypical variants, later onset, limited effect. There we are having autism three domains: communication, social interaction, and repetitive behavior. In the Asperger syndrome, we are having problem areas: social interaction, restricted stereotyped interest, differs from autism, normal cognitive and language development, and clumsiness. And then we are having hyperkinetic disorder, ADHD, neurodevelopmental cause, early onset. Boys are more prone to hyperkinetic disorder than girls, show lack of persistence in activities requiring attention, move from one activity to another without completing. And then we are having attention deficit hyperactivity disorder, common presentation, accident prone, socially disordered relationship with adults, aggressive, disciplinary problems, associations are below average intelligence or mild handicap, epilepsy. Then we are having attention deficit hyperactivity disorder. So they are having the behavioral modification. Methylphenidate is the drug of choice here. Tranylcypromine is also the drug of choice in the ADHD. Ritalin, it is a amphetamine, CNS stimulant, must be used under specialist supervision, must be periodically withdrawn to verify still working. Controlled, scheduled to MDA drug. ADR is weight loss. Substance abuse or misuse, we are having glue or solvents, tobacco, alcohol, and drug. So drug abuse, alcohol abuse, tobacco abuse, and glue and solvents abuse are the substance abuse with the your children. Okay, in the adolescent and children. Then we are
Sir,
having
we treated and made okay? Can we treat these children and make them okay?
Ma'am, in the substance misuse disorder, it is you have to take the child or the adolescent for both. There is a same line of treatment. You have to take the child or the adolescent to a recreational facility, to a center where the patient is given another drug to counter the effects of the withdrawal symptoms. Uh, Ma'am, you know the withdrawal symptoms?
Yes, sir, I know that.
Okay. So if a person like if I am addicted to smoking tobacco, okay, I am addicted to smoking or chewing tobacco, and daily I uh, take 30 cigarettes, 40 cigarettes a day, and somehow I have been put into a prison or a facility where I am not getting a single cigarette. So withdrawal symptoms will be there, and that withdrawal symptoms will be like very uh, powerful. It is very anxiety. It is the patient is
Mm.
it wants the that na cigarette or that bidi or tobacco. So to counter that, they give you a nicotine chewing gum. Okay, ma'am.
Yes.
So same thing with the alcohol. They give you something else to the alcohol. Then solvents and glue, they give you
So
something else. Bec-
in Bangladesh, we have all the street arches. We have a lot of street arches on the road, and they're all taking these glue things in the polythene bag.
Same,
So
ma'am, same in India, same problem. And in India, we have many of the brands of the glue has been banned due to this. But somehow they get source and they children's of the
they
that
are because they they go into criminal activities, and now they are
criminal
the
activity.
teenage hooligans, and this is creating the
14
problem.
year, 13-year child, 15-year of child, they used to snatch the purses, pickpocketing.
So they
Uh,
are setting a fire in everything. We have a big problem in Dhaka right now from the
yes, ma'am,
last month.
yes.
So there are a lot of people like this in the streets. So okay, sir. This can be treated or they cannot be treated, sir.
They can be treated. But as I have told you, it is very single line of treatment. You have to take the patient to a facility where you have to stop the
Blue.
tobacco, alcohol, drug, any drug. Okay, then you have to give other drugs, other medicines to counter the only to counter the withdrawal symptoms or withdrawal effect of the drug. Okay, when you are okay after 30 days, 40 days, the patient has not taken any drug, and slowly you have to decrease the dose of the medicines you are giving for the withdrawal symptoms. Then you can ask the patient to go home and live your life. Okay,
Okay, sir.
we can do it, but first we have to take the person from that environment to another environment. In India, we are having in mountains, in Nepal, in Tibet, in our in India, where are the Himalaya mountains. We are having such homes, shelter homes, such types of ashrams, where we take these people to them, and the treatment there, the psychiatric treatment is there. Sometimes they have become very violent. The patient is very violent, so you have to. They are caretakers. They make sure that